Okay, let's dive in. We've got this set of notes and research here on a really common health topic, bacterial vaginosis, or BV.
hmm
And we're basically going to unpack it. Think of this as, your fast track to getting properly informed, pulling out the really key stuff.
And it's definitely a topic worth diving into. BV is, well, it's incredibly common.
Yeah.
And understanding it properly, like the material shows, goes beyond just listing symptoms.
Right.
It's really about grasping that underlying shift,
Yeah.
the microscopic level, and why that impacts diagnosis and management too.
Absolutely. So that's our mission today. We'll walk through this material, define BV, look at what causes it, who might be more likely to get it.
Yeah, the risk factors.
Exactly. And explore what's actually happening biologically, how it tends to show up, how doctors diagnose it, the treatment options, and, the potential outcomes.
It's a full picture, really trying to pull out that core knowledge for the sources.
Let's jump straight in then. First things first, what is bacterial vaginosis exactly?
Okay, so the material's pretty clear here. It calls it a common vaginal infection, but, and this is the important bit, it stresses it's not just one single bug causing trouble.
Ah, okay. So not like a typical infection.
Not exactly. It's fundamentally an imbalance of the normal, healthy bacteria that usually live in the vagina. That's the key concept.
An imbalance. Got it.
Yeah.
And what does that imbalance look like? What's changing?
Well, the main thing is a big drop in the good guys, the protective bacteria called lactobacilli.
Lactobacilli, right?
Right. And when their numbers go down, it has a direct effect. The vaginal pH starts to climb. The material mentions it goes from its usual acidic state, like below 4.5, up to maybe around 6.
Wow, that's quite a jump in pH.
It is. And that less acidic environment lets other types of bacteria, especially these anaerobic ones, the ones that don't need oxygen, really start to multiply and take over.
Anaerobic bacteria, the material mentions specific ones, right? Like Gardnerella vaginala.
Exactly. Gardnerella is often mentioned, but also others like Prevotella, Mycoplasma hominis, and Mobiluncus. They thrive in that changed environment.
Okay, and there's this point the material makes early on about STIs.
Ah, yes. That's a really important nuance. It's made clear that BV isn't technically considered a sexually transmitted
I
infection,
had that.
but it is strongly linked with sexual activity. So it's not transmitted in the same way as, say, chlamydia, but sexual activity definitely plays a role in its development for many people. It's a distinction worth remembering.
Definitely. Okay, so it's an imbalance, lactobacilli down, pH up, anaerobes overgrow. What actually causes this imbalance to start? The etiology bit.
Yeah, the material says the precise initial trigger isn't always known, which is interesting. But the mechanism itself is well understood.
Here it is.
It's that rapid overgrowth of those anaerobes we just talked about, Gardnerella and the others. They basically outcompete and push out the beneficial lactobacilli.
So something disrupts the normal ecosystem, which leads us nicely into risk factors. Who is more likely to experience this kind of disruption? This part of the notes had some interesting points.
It really does. So things related to sexual activity are definitely on the list. New or multiple partners, having other STIs. That makes sense given the link we just discussed.
Okay.
The material also mentions ethnicity, noting it's more common in women of Afro-Caribbean descent.
And then there were some physical things, like a copper IUD being a risk factor.
Yes, that's listed. But the ones that often catch people's attention are about hygiene practices. Vaginal douching is explicitly mentioned.
Right, douching, and certain washes, even bubble baths.
Exactly. The material really highlights these. The idea is that these things, even if used with good intentions, can actually irritate the area or, crucially, disrupt that delicate bacterial balance.
Making it easier for the imbalance to happen. Kind of counterintuitive.
It really is. It suggests that sometimes less is more when it comes to vaginal hygiene products.
Fascinating. The list in the material goes on. Receptive oral sex is mentioned, particularly highlighting risk for women who have sex with women.
Smoking is also listed as a risk factor.
And hormonal changes, too, like during pregnancy or around menopause.
Yes, pregnancy comes up a few times because of potential complications, which I'm sure we'll get to.
We will. But the material also gives us the flip side, protective factors.
It does. Things like using the combined oral contraceptive pill. The estrogen is thought to help maintain the lactobacilli.
Makes sense.
Condom use also seems protective. And having a circumcised partner is mentioned as potentially reducing risk.
Okay, quite a range of factors influencing risk. So we know the players, the risks. What's the actual step-by-step process, the pathophysiology?
Well, in simple terms, it starts with that overgrowth of Gardnerella and the other anaerobes,
Okay, they start multiplying.
which disrupts the whole microbial community,
leading to fewer protective lactobacilli.
which then causes that rise in vaginal pH we talked about.
And that altered environment is what ultimately leads to the characteristic symptoms like the fishy odor and discharge.
Precisely. It's that chain reaction the material lays out.
Got it. Now, before we get to the symptoms people might notice, the material talks about differential diagnosis, basically. What else could it be?
Yeah, and this is super important because not all discharge or irritation means BV.
Right. Need to rule other things out.
Absolutely. The material lists quite a few possibilities. You've got other infections, like yeast infections, candida, or trichomoniasis, and of course, STIs like chlamydia, gonorrhea, herpes.
And you need to know which it is because the treatments are completely different.
Exactly. Then there are non-infectious causes. Things like just normal physiological discharge that varies between people, or irritation from soaps or fabrics, maybe even a forgotten tampon or other foreign body.
Okay.
Pregnancy itself can change discharge, things like cervical ectropion, even discharge after surgery.
And for older women?
Postmenopausal atrophic vaginitis is definitely on the list of differentials, and though much rarer, the material mentions considering tumors, even allergic reactions.
So the key takeaway here is symptoms need proper investigation. Don't just assume it's BV.
Couldn't agree more.
All right, how widespread is this? Let's talk epidemiology. How common is BV really?
The material describes it as the most common cause of vaginal discharge for women of reproductive age, certainly in the UK.
The most common cause?
Yeah. But the actual prevalence rates reported in the material show quite a bit of variation.
How so?
Well, it might be as low as, say, 5% in college students who don't have symptoms, but maybe around 12% in pregnant women, and then jumps up to maybe 30% in women attending clinics for termination of pregnancy.
That variation probably links back to those risk factors we discussed, right? Like levels of sexual activity, maybe other health factors.
Very likely. It confirms it's definitely more common in sexually active women, and also, as noted, in women who have sex with women, though the material does caution about confounding factors there.
So a really common issue affecting a lot of people, but not always causing symptoms.
That's the crux of it.
Which leads us perfectly into the clinical presentation. If someone does have symptoms, what do they typically experience? What does the material say it looks and, well, smells like?
The classic description is a thin, sort of grayish-white vaginal discharge.
Okay, thin and grayish-white.
And the really characteristic feature is a distinct fishy odor.
Ah, yes, the odor. The material mentions it can be more noticeable at certain times.
That's right, often after sex or during a menstrual period. It also mentions some people might experience mild itching or irritation, maybe some burning when they urinate.
Mild irritation, though, not usually intense.
Generally described as mild and often without significant redness or inflammation, unlike, say, a bad yeast infection. But here's the statistic that really stands out in the material.
Let me guess. The asymptomatic part.
Exactly. Around 50%, half of individuals who technically have BV, according to diagnostic criteria, have absolutely no symptoms whatsoever.
50%? That's just incredible. It really changes things, doesn't it? If someone doesn't feel anything, they won't seek treatment.
Precisely. Which makes the diagnostic process even more critical when symptoms are present or if screening is done for other reasons.
So how do clinicians confirm it? What are the investigations involved?
Okay, so the material outlines a few steps. It usually starts with a clinical picture, taking a history, asking about symptoms.
Makes sense.
Then a vaginal examination is key, and specifically testing the vaginal pH. As we said, a pH over 4.5 suggests BV, but it's not totally specific. Trichomoniasis can also raise the pH.
Right, so pH is a clue, but not the whole story. What else?
Microscopy plays a big role. There's the whiff test.
The whiff test. Sounds pleasant.
Maybe not. You add a drop of potassium hydroxide solution to the vaginal discharge sample. If it releases that classic fishy odor, the test is positive.
Okay. And under the microscope itself?
You're looking for specific things. Firstly, clue cells. The material describes these as vaginal epithelial cells that look like they're studded or coated with bacteria.
Ah, the bacteria sticking to the cells.
Exactly. And just as importantly, you're looking for the absence or scarcity of the normal lactobacilli. So you see the bad guys coating the cells, and the good guys are missing. It connects directly back to that imbalance, the pathophysiology.
That makes perfect sense. And there's a specific set of criteria mentioned.
Yes, Amsel's criteria. This is a standard diagnostic tool outlined in the material. You need 3 out of 4 specific signs to confirm BV.
3 out of 4. What are the 4?
Okay, they are 1, the characteristic thin white-gray discharge. 2, a positive whiff test. 3, vaginal pH greater than 4.5. And 4, the presence of those clue cells on microscopy.
Got it. Discharge, whiff test, pH, clue cells, need 3.
That's the standard clinical diagnosis. The material also briefly mentions the Eisenhower criteria, which is another grading system based purely on the microscopic appearance of the bacteria.
And a really crucial point the material emphasizes about diagnosis.
Ah, yes. Simply finding Gardnerella vaginalis bacteria in a sample on its own is not enough to diagnose BV.
Why is that?
Because, as the material notes, Gardnerella can actually be part of the normal vaginal flora in up to 40% of women who don't have BV.
Wow. Okay, so it's about the whole picture, the imbalance, the criteria, not just finding one type of bacteria. That's key to avoid misdiagnosis.
Absolutely critical. It's about the signs of imbalance, not just the presence of one potential player.
The material also touches on empirical diagnosis.
Yeah, basically treating based on strong symptoms and low risk of other infections, maybe if microscopy isn't readily available. And it includes practical tips, like how to actually measure the pH properly, swab the sidewall, not the cervix, use the pH paper correctly.
Good practical details. Okay, so let's say BV is diagnosed. What's the plan? How is it managed according to the material?
The main goal, obviously, is to treat the symptoms if present and try to restore that healthy vaginal balance.
And how's that done?
The primary treatment described is antibiotics that target those anaerobic bacteria, usually metronidazole or clindamycin. These can be taken as pills or used as creams or gels directly in the vagina.
Oral or topical. Okay. What about probiotics?
The material mentions them, specifically probiotics containing lactobacilli, as potentially helpful, maybe for restoring the balance. But it also notes elsewhere that the evidence for their effectiveness is a bit mixed or requires more research.
Okay, so antibiotics are the main thing. And presumably avoiding those irritants we talked about.
Yes, the material reinforces avoiding douching and harsh soaps or hygiene products.
Now, how well does treatment work? And does it stay gone?
Well, the initial success rates with the antibiotics are pretty good. The material quotes around 70–80% cure rate in terms of symptom resolution.
That sounds positive.
It is, but, and this is a huge but highlighted in the material, the recurrence rate is really high.
How high?
It says up to 50% of women might have a relapse within just 3 months after finishing treatment successfully.
Wow, half relapse in 3 months. That's a massive challenge. It suggests just killing the anaerobes isn't always enough to fix the underlying imbalance long-term for everyone.
Exactly. It's a major issue in managing BV. The material also mentions specific considerations, like in pregnancy. Clindamycin might be preferred in the first trimester, metronidazole later.
Right. And there was an extras section in the material with some key points.
Yes, some really important takeaways there. Like, asymptomatic women usually don't need treatment.
Unless
They're pregnant or undergoing certain gynecological procedures where BV increases risks. Also, it states there's no single antibiotic regimen that's definitively better than others.
Okay. And for breastfeeding women.
Intravaginal treatment is often preferred. And, crucially, differentiating it again from STIs, the material is very clear. No routine testing or treatment of male partners is necessary.
That's a really important practical point.
Definitely. It also flags that vaginal creams and gels might weaken latex condoms.
Good safety point. What about those frustrating recurrent cases?
Yeah, for recurrent BV, the material admits there isn't one standard proven long-term fix. But options like using metronidazole gel preventatively for several months or something called acid-drimer gel are mentioned as possibilities to reduce recurrences. Antiseptics, it notes, aren't effective.
So managing recurrence is tricky. Now, besides the symptoms and the recurrence, are there other potential negative consequences? What about complications?
Yes, and some are quite serious. The material clearly states that having BV significantly increases a person's risk of acquiring and transmitting HIV,
Wow.
and also increases the risk of getting other STIs, like herpes, gonorrhea, chlamydia.
This link to STIs is a major public health aspect of BV.
That's a really significant complication, and the pregnancy ones we hinted at.
Yes, the material lists several increased risks during pregnancy for those with BV. Late miscarriage, preterm birth, delivering the baby too early, premature rupture of membranes, waters breaking early, low birth weight babies, and also postpartum endometritis, which is infection of the womb lining after birth.
Okay, that explains why treatment in pregnancy is considered carefully.
It does, although interestingly, the material also points out there's currently no evidence to support routine universal screening for BV in all pregnant women. And the evidence for treating asymptomatic BV in pregnancy is limited unless the woman has other risk factors for preterm birth. So it's nuanced.
Nuanced indeed. Okay, finally, what's the overall outlook, the prognosis section? Well, the material does mention that sometimes BV might resolve spontaneously without any treatment at all.
Oh, really?
Yes. But balancing that is the point we keep coming back to, that very high rate of relapse.
Hmm.
The material reiterates figures suggesting maybe up to 70% recurrence within 3 months in some studies, even after successful treatment.
So for many, it's less of a one-off infection and more of a recurring condition that needs ongoing management or strategies to prevent relapse.
That seems to be the reality for a significant number of people, unfortunately.
Wow. Okay, that was definitely a deep dive. We've really unpacked BV using this material, starting from what it actually is, that imbalance.
Yeah, the lactobacilli, the pH shift.
Exactly. Through the causes, the risk factors, including the surprising ones like douching, how it presents, or crucially, how it often doesn't present with that 50% asymptomatic rate.
And the diagnosis Amsoll's criteria, the clue cells, needing that full picture.
Right. Then management, the antibiotics, the challenge of that high recurrence rate.
And finishing with those really significant potential complications, especially the links to STIs and pregnancy problems.
It really hits home that something so common can be quite complex underneath. Understanding the why, the microbial shift, the pH makes the diagnosis and the challenges make more sense.
Absolutely. And remembering key facts like half of cases being asymptomatic or that partner treatment isn't needed, those are the kind of high-yield points from the material that are crucial.
Definitely stick with you.
And all this, it raises a broader thought, doesn't it? Considering how common BV is, the potential for serious links to STIs and pregnancy outcomes, and then you factor in that huge number of asymptomatic cases and the difficulty with recurrence. What does that tell us maybe about how important general awareness is? Understanding our own bodies, the value of routine checks, and maybe being open to discussing subtle changes or risks with healthcare providers, even without obvious red flag symptoms.
That is a really powerful point to reflect on. Thinking beyond just the obvious symptoms, we really hope this deep dive through the BV material has left you, our listener, with a clear, useful, and solid understanding of this condition.